Assalamu alaikum. This is one of the important lectures. It's about the hypertensive emergencies. This is an important topic that you will face a lot while you are working after this. I hope you enjoy it and to be presented in a practical way. First, we have to know some definitions. Number one, what are the hypertensive crises? This means acute severe elevation in blood pressure that may or may not be associated with target organ dysfunction or target organ damage. So we have to know what is the hypertensive emergency. The hypertensive emergency means an acute severe elevation in blood pressure, usually more than 200 mm mercury systolic over 120 diastolic, with the presence of a target organ damage. Target organ damage may be stroke, may be cerebral hemorrhage, may be cardiac failure, may be pulmonary edema. This is what's meant by target organ damage. Also, we have to differentiate hypertensive urgencies from hypertensive emergencies. Hypertensive urgencies mean acute elevation of the blood pressure also, but in urgencies it's not associated with target organ damage. So when you see a patient with hypertensive emergency, you have to ask yourself three questions. The first, is there acute organ dysfunction or damage associated with this severe elevation of blood pressure? Number two, is this organ damage or acute organ damage caused by the severe elevation of blood pressure, or it may be older or chronic before the elevation of blood pressure? Is the improvement of the blood pressure or the lowering of the blood pressure will improve this organ damage or organ dysfunction or not? If the answer of these questions is yes, so this means this is a hypertensive emergency. What may be the causes of hypertensive emergency? If we have a hypertensive patient that have his treatment or take his treatment regularly, what may be the cause? Number one, this patient may be non-adherent to his treatment. Number two, if he was taking beta antagonist or beta blocker or clonidine and you changed the treatment or you change the regimen of treatment without withdrawal of the beta blocker or clonidine, this may cause hypertensive emergency. This also may happen in some drug or drug food interaction, like if the patient is taking MAO inhibitors and tricyclic antidepressant. This may cause increase in the dose of the drug and decrease in the metabolism of the drug and cause hypertensive emergency. These all are attributed to the regimen of the treatment. The patient may have pheochromocytoma with rapid rise of the blood pressure suddenly and at certain time, and then the blood pressure decrease again. Sometimes with pregnancy, collagen vascular disease, these two happen in female usually, especially with systemic lupus. May happen with some drug addiction like cocaine and amphetamine. This may cause intoxication and rapid rise of the blood pressure, causing hypertensive emergencies. Hypertensive emergencies may cause organ damage that may cause microvascular, causing encephalopathy, preeclampsia, eclampsia. This happens at the level of the small vessel due to endothelial damage and inflammation, and may cause macrovascular disorders like congestive heart failure, aortic dissection, stroke, subarachnoid hemorrhage. These are examples. This table shows example of the end organ damage that may happen. Neurological, you can find cerebral infarction. This is the most prevalent one. Hypertensive encephalopathy, intracerebral hemorrhage or subarachnoid hemorrhage. Cardiovascular may find left ventricular failure, congestive heart failure, ischemia and myocardial infarction, acute kidney injury, elevated liver enzymes, retinal hemorrhage, and eclampsia or aortic dissection. This all are end organ dysfunction and end organ damage that may happen with severe sudden elevation of the blood pressure. So you have to take care whenever you see a patient coming with any of these complications, especially if they are associated with the elevated blood pressure. You have to lower the blood pressure in a certain manner that we will describe now. So for the investigation, you have to measure the blood pressure in both arms. You have to do a fundoscopic examination to look if there is retinal hemorrhage or not. Measure the blood glucose, creatinine, electrolyte, liver function, urine analysis for the proteinuria and hematuria. This investigation usually are to detect the cause that may have elevated the blood pressure like this, also to detect the end organ damage that may happen with this elevated blood pressure. So you do the investigation to detect the cause and the result, or what happened due to this blood pressure elevation. So now we have finished the first part about the hypertensive emergencies and the urgencies, definition and causes, and how to detect or the investigation to be done. Now for the treatment or the practical part. If you are in the emergency department now and you have a patient with sudden severe elevation of blood pressure more than 200 over 120 systolic and over 120 diastolic, and you are asked to manage this patient, first you have to find if there is end organ damage or not. If there is an end organ damage, so this is a hypertensive emergency, and you have to lower the blood pressure in a certain manner that we are going to prescribe now. If this is a hypertensive urgency, so there is no end organ damage, you don't have to rapidly lower the blood pressure, but instead you can gradually lower the blood pressure over 24 to 48 hours and avoid over aggressive correction in the blood pressure and over aggressive lowering of the blood pressure, because the organs of the body now in this patient are adapted to this elevated blood pressure. For example, the kidney is adapted for this elevated blood pressure, causing good renal blood supply. So if you rapidly lower the blood pressure, this may cause decrease in the blood flow to the kidneys, to the cerebral circulation, causing complication. So you have to lower it gradually over 24 hours to 48 hours. But in hypertensive emergencies, I know that the organs are also now adapted for this blood pressure, or may become now adapted for this blood pressure. But in the presence of end organ damage, you are now trying to protect this organ from complete or irreversible damage. So you have to lower the blood pressure rapidly, as I am going to describe now or explain now. Over the first hour, you have to decrease or reduce the mean arterial pressure by 25%, while the goal or the diastolic blood pressure more than 100. Over the next 2 to 6 hours, the systolic blood pressure 160 and diastolic 100 to 110. From 6 to 24 hours, like the previous 2 to 6 hours, and then over the 24 hours, the coming 24 hours, you can gradually lower the blood pressure. So again, this algorithm, you have to find if the patient coming with elevated blood pressure, signs of end organ damage. If no, so this is not an emergency, this is an urgency. If you find an emergency, you have to lower the blood pressure as we described before, except in some manners there is a different way to lower the blood pressure. So if the patient coming with hypertensive encephalopathy, you have to measure the blood pressure first to be sure that this is due to the hypertension, exclude other causes, do the electrolyte panel to exclude hyponatremia and hypernatremia that may cause the disturbed conscious level, do CT brain to exclude cerebral hemorrhage or cerebral stroke. You have also to measure the serum creatinine to be sure that it's not uremic encephalopathy. If you have excluded all the other causes that may cause this hypertensive encephalopathy or the disturbed conscious level, and you have elevated blood pressure more than 180 over 110, so this may be a hypertensive encephalopathy. You can also examine the retina, fundoscopic examination to exclude retinopathy that may be present also, and it will confirm the diagnosis. In this patient, the treatment goal is to lower the blood pressure about 25% within the first hour, and then you can lower like we described before. Also, which confirms the diagnosis that the patient, after lowering the blood pressure, the conscious level of the patient will improve. This also may confirm the diagnosis that this patient is hypertensive encephalopathy. In patient with severe elevated blood pressure that may be presented to the emergency department with dyspnea, and on examination there is bilateral crackles and crepitation on both sides of the chest. This means that the patient has passed to acute congestive heart failure and pulmonary edema, and this patient you have to lower the blood pressure, and you better give this patient nitroglycerin and diuretics so you can remove the excess fluids from his lung and relieve the dyspnea and relieve the symptoms of the congestive heart failure that cause the pulmonary edema. And the nitroglycerin will decrease the preload and the afterload on the cardiac muscle so the patient can improve well. So these are the drugs of his choice in this patient: nitroglycerin and diuretics. Also, from one of the most important complications that may happen in this patient is acute aortic dissection. We have type A and type B. In type A and type B, you have to manage this patient rapidly in both types. In type A that and type B, in which the patient have malperfusion syndrome, rapidly progressing dissection and or enlarging aneurysm, inability to control the blood pressure with medications, the aortic dissections are in these cases a surgical emergency. But in most patients with type B, it's non-life. If the patient have non-life threatening type B, you can manage by medical treatment. In aortic dissection, we have two goals. The first goal, to reduce the heart rate below 60 beats per minute. This is very important. The next goal, or the second goal, is to lower the systolic blood pressure lower than 120, as low as clinically tolerated by the patient. In this case, we are not going to lower the blood pressure 25, the mean arterial pressure 25% within the first hour. No, we are going to lower as much as possible or as clinically tolerated by the patient, because if you are not going to lower rapidly the blood pressure in this patient, he may have rupture of the aorta and severe hemorrhage and death. So you have to lower the heart rate lower than 60 beats per minute and lower the systolic blood pressure less than 120, as low as clinically tolerated by the patient. So if I ask you what is the drug of choice that may lower the heart rate and at the same time lower the blood pressure, sure, the answer is the beta blocker. A beta blocker can lower the heart rate and lower the systolic blood pressure, especially labetalol. Also in patient with acute ischemic stroke. Now in this patient, the brain is adapted to the elevated blood pressure. So if in this patient, if you lower the blood pressure rapidly, this may cause decrease in the cerebral perfusion. So this patient is the opposite to the patient with aortic dissection. In aortic dissection you have to lower rapidly, but in patient with acute ischemic stroke you have to lower the blood pressure only to 160 to 140, not lower than 140, to avoid the decrease of the cerebral perfusion, to maintain the cerebral perfusion pressure as much as possible so the patient can maintain a good conscious level and avoid the brain edema. Except in 3 situations you can lower the blood pressure rapidly if there is other target organ damage like aortic dissection or myocardial infarction, so you have to lower rapidly. Now you are going to use a thrombolytic therapy to dissolve the thrombus. So if the blood pressure is high, this may cause hemorrhage, so you can lower rapidly. If the blood pressure is severely elevated more than 220, systolic or the diastolic more than 120, so you may lower rapidly but not less than 160 to 140 systolic to avoid the severe decrease in cerebral perfusion and brain edema. One of the important target organ damage that may happen with the elevated blood pressure or hypertensive emergency is the intracranial hemorrhage. In these patients are at risk, and these patients with intracranial hemorrhage you have to monitor very well while reducing the blood pressure to avoid also the decrease in cerebral perfusion pressure. So these are examples of the drug that can be used in hypertensive emergency. As you can find, all of these drugs are used intravenous infusion to lower the blood pressure by an expected and monitored way to avoid rapid reduction in blood pressure in certain situations, so you can follow the decrement or the lowering of the blood pressure well. So you can find here that these drugs have onset within minutes and some within seconds, and their duration act within minutes. I don't want you to remember all these doses, this is very difficult, but this example of the drugs that used. But here this is very important to know the drug of choice to be used in each situation. As you can find here, in pregnancy we can use hydralazine. In case of chronic ischemia or infarction or left ventricular failure, pulmonary edema, as I told you, you can use nitroglycerin. In cases of aortic dissection we can use ismolol, which is a beta blocker, and labetalol also, which is a beta blocker, metoprolol, another beta blocker. These can be used in aortic dissection. In patient with catecholamine excess or pheochromocytoma we can use phentolamine, which is both alpha and alpha, which is an alpha blocker, to avoid the severe rise of blood pressure if you use the beta blocker alone. So all these are the drug of choice that can be used in these situations. One of the important points, how to calculate the mean arterial pressure. I told you you have to decrease the mean arterial pressure by 25%. So we can, it's to calculate it, it's the diastolic blood pressure plus third systolic minus diastolic. The diastolic blood pressure plus third systolic minus diastolic. And finally, thank you.